Hi there, my name is Leonard. I'm one of the Dermatology SD4s working in Queen Elizabeth Hospital, and today I'm just going to present a few dermatology emergencies and things that we might often get called about coming in from the emergency department or particularly severe dermatology presentations that we might be consulted about. So I'm going to cover a few topics. The main thing really is drug rashes. That's what we get called about a lot. So trying to identify what is just a simple drug rash, which is very common, which won't really cause any significant issues, versus what we call severe cutaneous adverse reactions, such as Dress syndrome, AGEP, or Stevens-Johnson's and 10. And I'll probably go into a bit more detail about Stevens-Johnson's and 10 than the others. And then finally, we might just talk a bit about erythroderma. So drug reactions. So skin is one of the commonest targets for an adverse drug reaction. And the commonest type of drug eruptions are exanthematous or urticarial type of drug eruption. And I'll show some images of them later. Now, 2% of all drug-induced skin reactions are serious. So the majority are fine, but the serious ones do have an increased risk of hospitalization, prolongation of hospitalization, and even in some cases, disability and death. So it's very important to be able to identify what is a severe cutaneous adverse reaction. And particularly in these cases, it's key that the offending agent is identified and stopped. So drug reactions tend to be often they are immunologically mediated. And so you can get a type 1 hypersensitivity reaction, in the cases of maybe urticaria, angioedema, and anaphylaxis. Sometimes it can be related to immune complex deposition, and this can be seen in vasculitic rashes or in urticarial vasculitis that can be due to drugs. And then kind of the common ones we see would be a type 4 reaction in which you'd get an exanthematous rash, but they can be on the more severe end of the spectrum, which would be Dress syndrome and Stevens-Johnson's or toxic epidermal necrolysis. So, what are the main? There are quite a few different severe cutaneous adverse reactions, but the ones that I might discuss today will be Dress, AGEP, Stevens-Johnson syndrome, and TEN. There are other ones. So obviously anaphylaxis, which I don't feel I need to go into detail. I'm sure you're all quite au fait with that. And then there are other ones such as anticoagulant-induced skin necrosis. So that could be related to warfarin or heparin. And sometimes you can get this thing called a generalized fixed drug eruption, which basically fixed drug eruption is where you often get localized blisters, which can be on the mucous membranes or on the skin. And oftentimes it's very localized. However, sometimes you can get a generalized variant of this, which can be severe. And these blisters often tend to be quite tense, large blisters that heal with hyperpigmentation. So how do you identify what are the drug reactions that you need to be worried about? So it's often divided into a simple drug eruption versus a more severe complex drug eruption. One lecture I went to once introduced the concept of Shear's diagnostic triangle. So what you try to do is try to work out what is this type of rash on three different categories. So one is the appearance of the rash. Two is if they have any systemic symptoms, and usually they'll have a fever if it is a rash with systemic involvement. And then three, we do a biopsy to get further clarification. So what are the different types of morphologies of the rashes? So here you can see an urticarial drug rash in which the skin appears quite swollen and puffy. So you get what you call the wheal, which is the edema of the skin, and flare, which is the erythema. Here you have the classic exanthematous, or what also called morbilliform, or sometimes called maculopapular type of appearance, and it often looks measles-like. The kind of classic differential when you see a rash like this is it a viral exanthem or is it a drug? And this is, I'm sure you've all seen a few rashes like this in the past. It's exceedingly common. And then there's pustular drug rash. So when you look closely at the rash, you can see these little yellow or greeny fluid-filled lesions, which you call pustules. And then blistering drug rash. So I mentioned tense blisters earlier that you can get in fixed drug eruption. So this could be an example of a fixed drug eruption there on the left. of course, there are other things you need to consider, like bullous pemphigoid or other blistering diseases. And then on the right, you can see quite a superficial blistering, which is affecting much of the body. And this would be a case of toxic epidermal necrolysis, which again we'll go into later. So again, going back to kind of trying to work out what the drug rash is. So this is quite simple, but you consider that it's a simple reaction if they don't have any fever, if they're well in themselves, don't have any derangement of LFTs or anything like that. So if it looks xanthematous, you just say it's an xanthematous drug rash. If it's urticarial, you'd say it's an urticarial drug rash. And if it's pustular, you'd say it's an acneiform rash. So that's quite simple. But then if they do have a fever, if they're in any way unwell, if they've got deranged LFTs or if they've got lymphadenopathy, you might think that this is a complex drug reaction. And if the morphology is xanthematous, you might be thinking dress. If it's blistering, so shallow blisters, as I showed earlier, you might be thinking Stevens-Johnson syndrome and TEN. And if there are pustules, you're thinking AGEP, which is acute generalized exanthematous pustulosis. So we'll move on to now DRESS, which is a drug reaction with eosinophilia and systemic symptoms. Although actually people do prefer it nowadays to be called drug-induced hypersensitivity syndrome, or DIHS. This tends to develop about 2 to 6 weeks after initiation of the culprit drug. But you can get a shorter latency period if they've already had the drug and have had re-exposure to it. The causative drugs tend to be sulfonamides, the anticonvulsants such as phenobarbital, phenytoin, carbamazepine, and lamotrigine, and allopurinol. I've put all these ones in bold because these ones tend to be the ones that come up again in the different types of drug reactions. So always keep these ones in mind. And then more specific maybe to address would be dapsone and abacavir. But there can be a whole range of medications that can be associated with it. So what happens? So in the skin, you often get this exanthematous rash, which I showed earlier, and oftentimes it can be focused initially around the hair follicles, and there can be quite a bit of swelling there as well. Typically involves the upper trunk, the upper arms, and the face. And the hallmark finding and thing to look out for is if they've got facial edema. That's a real pointer towards DRESS. If it's quite severe, they can get erythroderma, which is greater than 90% body surface area involved. And sometimes you can get different morphologies, but they are rare. So you might see atypical targets, which look a bit like erythema multiforme. Might see small little fluid-filled vesicles, blisters, pustules, or even purpura. And occasionally you can get mild mucosal involvement, but it's usually not that severe. So in the early phase, they'll probably just have a bit of malaise, fatigue, and they will have a high fever in 90% of cases. And you should always check for lymphadenopathy, which is often present in several sites. If you do bloods, they will often have an eosinophilia, although it might not be apparent early on in the course of the disease. And they can also have atypical lymphocytes. Occasionally, they can get a full-on pancytopenia. The liver is really the one you need to keep an eye on, which is very common involvement, about 70 to 95%. And it can vary from a mild transient hepatitis to a fulminant hepatic failure. And this can be either a hepatocellular or an obstructive pattern. So if I ever see a rash that there is an exanthematous rash and the team are querying drug reaction, the main things I always ask them to do is to keep an eye out for eosinophils and LFTs. But you do need to keep other organs in mind, so you can get renal involvement. It is rare, but okay, for hematuria, proteinuria, and eosinophils. I think the stain for eosinophils that you can check on urine is the right stain. Now, you won't need to do a biopsy in the vast majority of cases, but if you were to do a biopsy, sometimes you might see an interstitial nephritis. But thankfully, severe renal impairment is very rare. And then really you need to think of a range of organs. So you can get a pericarditis or a myocarditis. Again, it's rare, but it's serious. And pulmonary involvement is again rare, but they might get pleural effusions, pleuritis, or an acute interstitial pneumonitis. They can get a gastroenteritis or a pancreatitis. And very rarely you can get CNS involvement with inflamed meninges, so they can present with headaches sometimes. Another important thing to be aware of is that they can get hyper or hypothyroidism, but this tends to occur very late in the disease. So when they're being discharged, it should be noted to the GP that their TFTs should be monitored for 1 year after the acute event. So what happens if you get a particularly severe dress, they can get acute liver failure, so they can get coagulation problems, jaundice, and impaired consciousness. You can sometimes get multi-organ failure. You could get a fulminant myocarditis or even hemophagocytosis. So these are all things just to be aware of, particularly if they are unwell or if their labs are going off a bit. These are all potential complications. Investigation wise, so as mentioned, you do an FBC, particularly looking for eosinophils. You do a blood film to see if there's any atypical lymphocytes. Look at inflammatory markers. Your liver test, you just do an LFT coagulation profile and LDH. And then you can do various tests looking at the kidneys, looking basic tests for at the heart and the lungs might be an ECG and chest X-ray. And if there's any concern that there is involvement, you could do further investigations, as I've mentioned there. You should do TFTs as well. And really, the other tests, such as neurological tests or gastroenterology testing, would really be guided by their symptoms. And then we'd often do a skin biopsy. Unfortunately, though, it's really not that specific and it can show a variety of inflammatory patterns. So it might be useful to rule out other skin conditions. It might show a few eosinophils, which will be in keeping with a drug reaction. So it can be helpful, but it's often not fully diagnostic. So what is the management? So clearly you identify the culprit drug and remove it. If it's not too severe, you could just use a strong topical steroid such as Dermavate. But in most cases, when it's identified, they need oral prednisolone, tapered slowly over about 1 to 3 months. If that's not doing it, you might even require a short course of IV methylprednisolone. I think in general, that usually covers it most of the time. But second line, you could consider things like cyclosporin or IVIG, and failing that, you could even consider cyclophosphamide or plasmapheresis. So it can be fatal in about 10% of patients, and a poor prognostic indicators often it would mean FBC that is deranged in any way, history of chronic kidney disease, coagulopathy, multi-organ involvement, tachycardia, tachypnea, and systemic inflammatory response syndrome. So I'll move on now to acute generalized exanthematous pustulosis, and at least 90% of these are caused by drugs. And the causative drugs tend to be, again, different antibiotics, so beta-lactams, macrolides, quinolones, sulfonamides, and then maybe more specific to AGEP, you'd see diltiazem or different calcium channel blockers can cause it, antimalarials such as chloroquine and terbinafine. And then, interestingly, there are less strong associations, but things you should always inquire about are paracetamol and NSAIDs. Although sometimes it's difficult to work out, is that just a confounder and they have taken that, but it really is another drug that's causing it. So AGEP, as I said, you get a pustular type of rash. So at the image on the left, you can see very widespread erythema. And if you were to look closer at those areas of discoloration, you'd see little sterile pustules. And on the right, you might get a clearer appreciation of the little pustules. So you often get a rapid appearance of this coming on of dozens to hundreds of small, pinhead-sized, non-follicular sterile pustules. Patient may often have a bit of erythema or edema in the areas before these pustules appear, and they often describe an itchy or burning sensation. You might see the pustules more clearly in the various intertriginous areas, in the nape of the neck, and sometimes the face. And sometimes the little sterile small pustules can coalesce and look a bit larger. Like dress, you can also get other morphologies sometimes appearing. So you again might see atypical target lesions, you might see some purpura, you might see blisters or vesicles, and even in this you might see some facial edema. And atypical cases with an overlap with dress and TEN have been reported. So the patients will almost always have a fever. They might have high white cell counts and neutrophils and high CRP, and then occasionally they might have an eosinophilia, their albumin might drop, or they might have hypocalcemia. Thankfully, organ involvement is very rare, but you do again need to maybe just keep an open mind that the liver, the kidneys, or the lungs could be involved. Again, that'd be depending on blood tests and symptoms. And thankfully, it's usually not as severe as DRESS or TEN or SJ. So I suppose the major differential diagnosis for AGEP is a pustular psoriasis. Um, uh, and really, you often have to do a biopsy to try to differentiate it. Again, it's not always 100% diagnostic, but when you look at the biopsy in AGEP, you often see more features in keeping with eczema, almost something called spongiosis, and you often see quite a few eosinophils, whereas psoriasis shows what we call psoriasiform features. And I don't feel I need to go into detail about the different biopsy changes, but sometimes it can differentiate between the two. And another important clue to look out for is that pustular psoriasis patients may have a history of psoriasis. They may have a history of joint pains, and the main thing is that pustular psoriasis can often flare if a patient's been on strong topical steroids, or more often oral steroids that have been quickly withdrawn. So AGEP is usually a self-limiting disease. You obviously withdraw the offending drug where possible, and if it is severe, they might need to be admitted just to maintain thermoregulation, fluid electrolyte balance, nutritional support, and avoid infection. I'll kind of go into supportive care a bit more in when I talk about Stephen Johnson's and toxic epidermal necrolysis and erythroderma. But for the skin and AGEP, you might treat with antiseptic solutions such as Dermal 500 to wash with, and this helps prevent infection. Might use regular emollients like 50/50 ointment, which help restore skin barrier function. And then you can use a medium potency topical steroid such as Umivate ointment. If they are very itchy, you could consider sedating antihistamines. And only really in severe cases, you might consider a short course of systemic steroids, so maybe 1 to 2 week course of oral prednisolone. So now I'll move on to kind of the thing that people always say is the true dermatology emergency, and that's Stephen Johnson syndrome and toxic epidermal necrolysis. So thankfully it's rare, but it can be fatal, and it's a drug reaction that leads to keratinocyte death with full thickness necrosis of the epidermis, and as a result you get severe desquamation or peeling off of the epidermis in the skin and the mucosal surfaces. So it tends to exist on a spectrum. You look for detached skin or detachable skin. So that is either skin that is peeled off or skin that is about to peel off. So you can do that, check if it's about to peel off by rubbing on the area, and if it sloughs off, that's detachable skin. So if less than 10% of the body surface area is detached or detachable, we call it Stephen Johnson syndrome. If 10 to 30% is detached or detachable, we call it Stephen Johnson toxic epidermal necrolysis overlap. And if it's greater than 30% of skin affected, we call it toxic epidermal necrolysis. So the vast majority are due to medications, and over 100 causative drugs have been reported. But the main culprits are, and you'll see a recurring theme in some of these treatments, so sulfamethoxazole and trimethoprim tends to be the commonest. Allopurinol, anticonvulsants such as carbamazepine, phenytoin, lamotrigine, antimicrobials, in particular beta-lactams, anti-inflammatories such as NSAIDs, and antiretrovirals such as abacavir and nevirapine. Interestingly, patients with HIV tend to have a much higher chance of getting SJS or TEN. Infections sometimes can cause it, for instance, mycoplasma pneumonia. There is some debate about whether this should be classified as something different to SJS and TEN, but it can often give similar signs, particularly with more prominent mucosal involvement and skin involvement. So what happens? So usually it's about 1 to 2 weeks is the usual length since taking the first dose of the causative drug, but you really need to be suspicious of anything that they've started or any dose that they've increased over the last 8 weeks. They usually get a prodrome where they're feeling feverish and they have flu-like symptoms, and then 1 to 3 days later they get skin and mucosal lesions. And the mucosal lesions, you often see erythema or erosions. It's important as nearly all patients get mucosal involvement, so you really need to ask about and examine these areas. Really, if you ever consult us for a query a drug reaction that's severe, we will always ask for this. So yeah, please do. In the skin, the lesions usually begin on the trunk and face with erythematous macules, so that's really fat erythema, and what we call atypical flat targetoid lesions. So it often looks a bit darker in the center of these lesions. Um, it can be dusky or kind of purpuric or purplish in color, and that's often a sign of skin necrosis. And the patient will often complain of the skin being very painful, and it will be tender to touch. So after the patients develop erythematous and targetoid lesions, these lesions can coalesce in hours to days, and they progress to flaccid blisters and sheets of skin that start to desquamate. Check something called Mikulski's sign. So basically, if you put tangential pressure, so basically rub across unblistered skin, you get skin sloughing and blistering. The major differential diagnosis in SJS and TN is erythema multiforme major, because here you can also get mucosal involvement, and you can get targetoid lesions, which occasionally can blister to about less than 10% of the body surface area. So some differentiating factors would be that EMM tends to involve more distal extremities, such as the hands, predominantly compared to the more proximal areas in SJS and TEN. And in SJS, the targets tend to be atypical, so very irregular kind of shaped. They tend to be flat compared to these palpable target lesions you get in erythema multiforme. So this is an example of Stephen, kind of the rash you'd see in toxic epidermal necrolysis. So on the left, you can see this is kind of the beginning of it, really, where you get these what we call atypical targets that are often flat. And then on the right side, you can see some the yellow areas are kind of some tense, kind of flaccid blisters occurring, and you can also see on the upper abdomen there, you can see erosion, so that's blistered and peeled off. Here's some oral involvement. So with oral involvement, they'll obviously get hemorrhagic crusting, often on the lips. And then when you look inside, you'll see erythema and shallow erosions. And then you can also get eye involvement. So initially, it might just look very inflamed around the eye, and then you can sometimes get blistering. You can get a thing called symblepharon, which is basically attachment of the mucosa. So it almost looks like there's thick bands attaching the eyelid mucosa to the conjunctiva. So if you see a desquamating rash, what are the things you're thinking of? So of course you don't want to miss SJS and TEN. And what can often look very clinically similar is staph scalded skin syndrome and toxic shock syndrome. And you'll often do the skin biopsy is key, as the blistering in these two will be much more superficial than in SJS and TEN. There's a blistering disease called pemphigus vulgaris, and a test called immunofluorescence on the biopsy will often reveal antibodies that will diagnose this. And then other things that you won't go into too much detail, but again, atypical dress or AGEP can look similar. You can get an acute graft versus host disease, and sometimes when people are very unwell, they can get a thing called purpura fulminans. So the coags will be all off, and they'll get marked bruising throughout the skin, and so that can sometimes get necrotic skin as well, which can look similar. So what do you do when you see or considering SJS or TEN? So yeah, of course you ask simple things. So when and where on the body did it start? And tell me how has it progressed, etc., etc. One thing to always ask about is skin pain. This might indicate that you've got an evolving SJS TN, so that's quite a worrying symptom. And the most crucial part, of course, is the medication history. So you really need to get into as much detail as possible about this. In particular, you might want to get from various sources, so from the patients, from the GP, from the pharmacy, if possible. I know it can be difficult, but anything that's been prescribed, anything they've taken over the counter, any supplements, you might even consider things like eye drops that they might take, as it rarely can cause SJS/TN. You might ask them, have they had any recent infections requiring antibiotics, and if they've been in pain for anything and taken any painkillers, because they might neglect to say that they've taken things like ibuprofen. And really anything within 8 weeks can be relevant. Kind of some differentiating factors, you might ask them if they've had a recent respiratory tract infection or if they're prone to getting recurrent cold sores. As I was mentioned previously, erythema multiforme major can sometimes look like SJS. So if they do have cold sores, it might be more likely that it's erythema multiforme major. And then you just do a review of symptoms. So, as I said, ask about skin pain, ask them if they've had flu symptoms before the rash came on, and then get more into kind of areas that might be affected. So, ask them about eye changes, so vision change or photophobia, ask if they've had any nosebleeds, ask if they've had a sore throat or painful swallowing, ask if they've had pain on urination, and then very rare, occasionally, SJS or TEN can cause problems with the respiratory or the gastrointestinal mucosa. So you also need to ask about symptoms about them, and in particular, if they've got respiratory involvement, you may need to consider escalating things even more urgently. So on examination, they'll almost always have a fever. Again, mucosal membranes are almost always involved, so you get hemorrhagic crusting, blisters and erosions. The rash, as mentioned, you get erythematous macules, and a dark purple colour suggests necrosis. And then you can get shallow blistering and erosions, and your Nikolsky sign positive. A useful thing is to calculate the body surface area that's involved. So you can calculate two things. You can calculate the red inflamed areas, and you can also calculate the detached or detachable areas. And one good rule is the rule of nines. So the head represents 9% of body surface area, each arm is 9%, and then 18% for the front of the torso, 18% for the back, and 18% for each leg. Another quick calculation, if it's not as much as surface involvement, is that palm of the hands, including the fingers, equals 1% of body surface area. It's also important to look for lymphadenopathy. So what investigations do you do? So standard investigations, so you do FBC, UNE, NFTs, coagulation profile. You want to look at the electrolytes, so bicarbonate, magnesium and phosphate. You might do a glucose, and then you want to check for HIV. As I mentioned, HIV there's more chance of catching SJS/TEN. You might do mycoplasma serology, and just make sure they haven't had a recent mycoplasma, which could be causing symptoms. And then you might want to do bacterial swabs from lesional skin. And if there's any concern about herpes simplex virus, you might do viral swabs. And often you can get candida superinfection, so even fungal scrapings or swabs can be beneficial. The real key thing from the dermatology point of view is if we get called, we're going to do a skin biopsy and send it off for something called direct immunofluorescence. So SJS and TEN can be very severe, and so there's a prognostic score which is quite useful called the score 10. And you do this at presentation and again at about 48 to 72 hours into their hospitalization. There is an acronym called TAME-BUG, which kind of goes through what is in the score 10. So if they're tachycardic, greater than 120, if they're older than 40 years, if they have a current malignancy, if their epidermal loss is greater than 10%, if their bicarbonate is less than 20, their urea greater than 10, or their glucose is greater than 14. Each one of these is assigned 1 point. If they score 0 to 1, their predicted mortality is only 3%. However, as you can see, if their score is 4, it's about 58%, and if it's greater than equal to 5, it's 90%. Another factor that should be considered is their albumin, so it's not included in the score, but if this is very low, it can be a very worrying sign. So, as I said, we do a biopsy. One thing we might do is we might do 3 biopsies. So I might take 1 biopsy and I can send it off for frozen section immediately. And the pathologist will then be able to tell us exactly where the split in the skin is. And this might, as I mentioned earlier,
staff scalded skin syndrome often see a much more superficial thing.
So if they see a very deep blister immediately, it
Leads to a diagnosis of SJS or
TN urgently. But then we'll just do a standard, send the standard biopsy off for standard H&E. And on this, you'll see keratinocyte death or necrosis throughout the epidermis. And initially, it might only be a few keratinocytes, but as it progresses, you get full thickness keratinocyte epidermal necrosis, and you'll see deep blister formation. And then we also always send off a thing for direct immunofluorescence, and this can help diagnose autoimmune blistering diseases like pemphigus vulgaris, which can often look quite similar clinically.
So the acute complications of
SJS and TEN. So really, you've got total skin failure. As we all know, skin has many functions, and so in SJS10, you can get thermoregulatory dysfunction, you get large and sensible fluid losses, you can get hemodynamic instability, it can lead to systemic sepsis, which tends to be the most frequent cause of death,
and then you can get hematological problems, kidney problems, and liver dysfunction. So what's our immediate management plan when the patient comes
right into A&E? So really, if you're suspecting SJS, TN, discontinue
any potential culprit drugs.
Try to get peripheral venous access, ideally in non-lesional skin. And then if you assess if they're able to maintain hydration and nutrition, so are they able to drink fluids or eat? And if not, get an NG tube in as soon as possible. And usually put in a urinary catheter, particularly if it's severe, as this can assist with monitoring of fluid input and output. And also if there's any concern that they've got urogenital involvement, it can help prevent strictures down the line. So oftentimes you might put in a urinary catheter.
So it's important to get them in
the right environment. So if it is severe, so really if their body surface area of epidermal loss is greater than 10%, they should really be admitted without delay to either a burn centre or, I suppose, more commonly in this instance here to ICU. But hopefully there'll be experience of treating patients with SJS and TEM. And really, if you delay transfer to the appropriate unit, it does lead to increased mortality. So really, it's getting them into the right area as soon as possible. Ideally, they should be nursed in a side room to facilitate barrier nursing, and the room should be controlled for humidity. And the ambient temperature should be raised to between 25 to 28 degrees Celsius. And this really reduces energy consumption and metabolic stress.
And you might put them on
an air fluidized bed as well.
So
skin management. So as mentioned, there needs to be strict barrier nursing. This reduces nosocomial infections. And hopefully the nurses will be trained in anti-shear handling of the skin. So that they know when to move or position patients, it reduces the risk of the skin peeling off. And where possible, you want to limit epidermal trauma. So avoid
overuse of blood pressure cuffs, adhesive ECG leads, wrist tags, adhesive dressings, all
these things. Try to really limit the use of them.
So if they do have, you want to leave the detached lesional epidermis
on the skin where possible, as this can act as biological dressing to the underlying dermis. If they do get quite large blisters or anything, you can aspirate the fluid, but you leave the roof on as this acts as a biological dressing. You want the skin to be and wounds to be regularly irrigated, either with warm, sterile water or saline. And it's very important that they're covered very frequently in a greasy emollient. So good one is using different sprays. So Immelin 50/50 spray is very good, or Dermamist is another one. And really the spray minimizes the shearing forces that might happen if you're applying it more with your hands. You want, if there's any lines to be fixated, often a soft silicone tape called Mepitac is useful, and hopefully that'll be present in most ICUs.
And it's very important if they do have any
denuded dermis to use a non-adherent dressing. So some examples of these would be Mepitel or Atramon. And oftentimes, if they've got lots of exudate coming out, you want to apply a secondary foam or burn dressing. Exudry is a very good suit, but there are other options that I've mentioned here.
And then other considerations. So
the really important thing is to monitor and manage infection. So you need to do frequent bacterial swabs. if you give systemic antibiotics when they're not infected, this can lead to colonization of more harmful organisms. So you really only give systemic antibiotics if there are any clinical signs of infection. So it can sometimes be hard to look out for infection, as a patient will often have a fever with toxic epidermal necrolysis. So just keep a close eye on the swabs. So if they previously had mixed growth in multiple areas and then they're getting a monoculture of areas, this could indicate infection. And then look out for other things like confusion, hypotension, decreasing urine output, increased skin pain, increased inflammatory markers, etc. So it's just important to be aware of it. And if there are concerns, you might need to start a systemic antibiotic. And the other very important thing is to look out for fluid balance carefully. So you look at the urine output, you look at other vital signs and measure lactate, and you replace as required and replace electrolytes as required. And then nutrition. So it's probably important to get a dietitian involved very early. You do get a hypermetabolic response in TEN. And again, of course, enteral nutrition is preferable to parenteral. So give an NG food if they can't take things orally. And really, the dietitian will be able to guide you on the requirements that they need for nutrition. They can be in a lot of pain, patients, particularly when they are being moved or handled. So get the acute pain team in early, and they often require an opioid-based regimen with top-ups prior to any handling or repositioning. If they're not getting stuff through the NG feed, they should be started on PPI. If they're immobile, they should be given venous thromboembolism prophylaxis. And sometimes neutropenia is associated with increased risk of infection. So some centres may consider recombinant GCSF therapy in these cases. And there's also some evidence that it may enhance reepithelialization. So this is something that can be considered. And then really it's important to get other teams involved. So think about the other mucous membrane areas that are involved and get the appropriate teams involved. I've written kind of quite a lot of detail here, but really essentially you want to get daily ophthalmology review who can recommend some different topical ointments and possibly steroids. They can also do something called ocular hygiene, in which they remove any adhesions found within the eye. You want to get oral medicine involved, again, for various topical treatments, plus or minus topical steroids. Urology would be important to review. So as mentioned, sometimes catheterization can prevent strictures, but they should really have a review as there's a long-term risk of strictures and stenosis of the urethra and phimosis. And then in women, really of all ages, it's important that someone, a vulval specialist, reviews. So they might perform a speculum exam looking for any adhesions, and they may actually put prophylactic dilators in, and that they may use topical steroids. It's important to be aware that vulval scarring can occur 1 year after the event, so they should be followed up by someone who is comfortable with following this up. Also, very key to look out for is any respiratory symptoms, so any hypoxemia, dyspnea, or tachypnea. So you can get necrosis of the bronchial mucosa, and this can slough off and cause obstruction. And this is a high risk of death, so it's really something to be aware of, and really they might need to be ventilated if they were to develop any of these symptoms. And then it's really quite difficult managing TEN. Apart from supportive treatment, there has been no real evidence that is sufficient enough to make specific recommendations for other active interventions. And so the BAD guidelines really suggest that such interventions should really be under the supervision of a specialist skin failure MPT in the context of a clinical study or a case registry. So they say that the withdrawal of the culprit drugs and meticulous attention to high quality multidisciplinary supportive care remains a priority. Treatments that have been considered and that may be used in specialist centres or in trials would be IVIG, oral steroids, cyclosporin, and as mentioned previously, granulite stimulating CSF. Now we'll move on to the final topic, erythroderma, which is also called exfoliative dermatitis. So erythroderma is essentially, it's just diffuse redness or erythema and scaling of the skin involving more than 90% of the body surface area, regardless of the cause. So really it's a clinical sign, and it can be due to a number of underlying potential causes. It tends to be more frequent in older adults, so the mean age is 40 to 60, and men tend to get it more often at around
ratio of about 2 to 4:1. So here you can see kind of a classic erythroderma case. The patient is red all over and has an extreme amount of scale. So this could be due to a number of things. If I was guessing, I'd say this is probably psoriasis, but it really depends on a number of factors. So at least 50% of cases of erythroderma are due to a pre-existing condition like psoriasis or atopic dermatitis. And as I said, there are numerous causes of erythroderma, and I'll go through a few of them briefly here. So it can be a papular squamous disorder, such as psoriasis, or something called pityriasis rubra-pilaris. It can be due to a dermatitis, so it can be due to someone who has a background history of atopic dermatitis or severe seborrheic dermatitis, or they could be coming in contact with something that they're allergic to, and it can be an allergic contact dermatitis. Drug rashes, as mentioned previously, they could get an all-over rash just from a simple drug rash that is not too concerning, or there could be more concerning features such as a DRESS or a SJS or TEN. Malignancy can sometimes cause erythroderma, and a certain type of lymphoma called Sézary syndrome, which is where they have cutaneous lymphoma, which presents as erythroderma, and they'll have atypical lymphocytes within the blood as well. And even solid organ tumours can cause a paraneoplastic rash that can lead to erythroderma. Infections, so a simple viral exanthum, or different things like staph scalded skin syndrome, a widespread tinea infection, or Norwegian scabies can lead to redness all over. Immune conditions, so lupus or dermatomyositis, or these bullous blistering disorders we often see called bullous pemphigoid or pemphigus vulgaris, or even something such as a sunburn could cause an erythroderma. But one important thing is that in about 30% of cases, even after investigations and monitoring for a period of time, still no cause can be found for it. So really, I suppose, just in summary, is you need to really cast a broad net when you see a patient with erythroderma, and it's important really to ask if they have any underlying disease, skin diseases in the past that might point towards a diagnosis. So erythroderma patients, they can have had this for weeks or months or even years, and they might be totally stable, and it's just something they have, or it can be very unstable with acute changes over hours to days, and in severe cases it can be life-threatening. So I suppose one pointer towards drug rashes is that it's often an abrupt onset. They may have the initial morbilliform or urticarial eruption that we discussed previously, and if it's due to an underlying disease, it may be a more gradual onset. And they might even have areas of rash with characteristic features before the full-on erythroderma occurs. So it can sometimes be handy to ask, do they have any photos of what the rash looked like prior to this full-on rash all over? The patients are usually itchy. This might be particularly severe in patients with atopic dermatitis or Sézary syndrome. And scaling is very common, particularly in psoriasis. They can get really excess scale. If they've had the erythroderma for a long period of time, it might feel very indurated and leathery on palpation. And then it can also, if they've got widespread erythroderma, it can also affect other structures. So they might get nail changes, so they might get nail dystrophy or shedding of the nail, which is called onychomadesis. If they can affect their hair, so they can just get generalized hair falling out, which is often due to an acute insult. So that's called cleavage in the fluvium. And it can affect their eyelids, so they might get just a bit of blepharitis, or sometimes they can get atropion, which is eversion of the eyelids. There are various clues when you're looking at the rash that might point to a specific diagnosis. So I'll just mention what pityriasis rubra-pilaris is. It's a widespread rash. It often can look a bit like psoriasis, but you get certain things when it is widespread. You get a thing called islands of sparing, which is basically skin in between the rash that is completely clear of any changes. It's often salmon pink or orange in color. And you often, if you look at the hands, it will often look, you get what we call palmoplantar keratoderma, that is waxy. So it often looks like thickened skin in the palmar surfaces. And if the rash isn't completely involved in the whole skin, you often get, the rash starts particularly focused around the hair follicles. If you see any blistering, it might point towards an autoimmune blistering disease or SJS and TEN. As mentioned previously, if they've got marked facial edema, it might point towards a drug reaction like DRESS. You look at the nails, and if you see specific nail pitting, they might think of psoriasis, or if they have a history of joint pains, you might think psoriasis. And again, you must examine the mucous membranes, which might point toward SJS or TEN, Pemphigus vulgaris, or even graft versus host disease. Apart from the skin features, they'll often have a variety of extracutaneous features. So patients will have poor temperature regulation, so they'll often feel shivery, they'll often have malaise and fatigue. Because the blood vessels are all really dilated out in the skin, they'll often have signs of high hypocardiac failure. So they can get peripheral edema, they can get tachycardia. What might also be making the peripheral edema worse is that a lot of the protein that they have is shed in the excess scale, and as that can further exacerbate the peripheral edema. With hypoalbuminemia, anemia, and in fact, peripheral edema isn't present in about 50% of cases of erythroderma. You should also look for lymphadenopathy. So it can really be seen in any erythroderma patients. However, if it is very pronounced, it might make you suspicious that they could have a cutaneous T-cell lymphoma, and you might need to refer for lymph node biopsy. You should also look for any acromegaly. So what investigations might you perform? So you do all the usual things. So you'll do an FBC. If they've got particularly high eosinophils, it might point towards a drug or just an atopic dermatitis. You'll do a blood film, and that will be looking for the atypical lymphocytes that you might see in the Sézary syndrome. And you can send off for a thing called flow cytometry, which will show you kind of CD4 to CD8 ratio, which if it's particularly high, might point you towards this diagnosis of Sézary syndrome. You look at their UNEs, monitoring for any electrolyte imbalance. You might do NFTs, which can be particularly deranged in a drug reaction like DRESS. And then you do other things like glucose, LDH, IgE might be high in atopic dermatitis. And you might do an ANA looking for lupus. And if there's any suspicion of dermatomyositis, you could even do an ENA, creatinine kinase, and do myositis-specific autoantibodies. It's important really to perform a few biopsies, as the changes are often quite non-specific. So we often have to do quite a few biopsies, as one biopsy mightn't show anything specific. And the other thing is that the specific changes that might make the diagnosis might only become apparent later in the time course of the disease. So if we don't have a full-on diagnosis and the patient's still erythrodermic months later, we might have to do a repeat biopsy. So for instance, in a cutaneous lymphoma, it might be apparent for a period of time. And then, as I said, if you see any atypical cells within the skin biopsy and you're worried about lymphoma, you can do other tests such as immunophenotyping and TCR gene rearrangement studies. But I'm sure you don't want me to go into too much detail about that. The other thing you might do in a biopsy is a thing called direct immunofluorescence, which can help diagnose a blistering autoimmune disease. Like SJS and TEN, it's important to do regular microbiology testing. So you'd want to do bacterial swabs. If there's any erosions that are painful, you might do viral swabs looking for herpes simplex or varicella zoster. And to the scale, you might do some fungal scrapings just to make sure you're not missing a tinea infection. And then it's very similar to SJS and TEN, and really you just want to look out for and manage any hemodynamic or metabolic disturbance. So look out for fluid and electrolyte imbalance, and put them in a hot room and monitor for humidity, as they can get hypothermic or they can even get a compensatory hyperthermia. You look for signs of high hypocardiac failure and look for signs of significant protein loss. If they do have any infections, you might treat with antibiotics, and you also have to have a low threshold for looking for herpes simplex virus. And this is really me repeating myself, but if they are unstable in any way, they require admission. You keep them warm, you monitor and replace electrolytes, you monitor hemodynamic status, and you give them nutritional support. For regards to skin management, they should be treated with regular emollients. So again, you can use 50-50 ointment. Again, you wash with an antibacterial wash such as Dermal 500.
And you can consider topical steroids. And the one thing here is that if there's any suspicion that it might be psoriasis, you probably shouldn't give too strong a steroid as it puts them at risk of pustular psoriasis.
So you might only start them with Humavate ointment, which is a moderate topical steroid. And this, though, even differs between dermatologists who sometimes give something stronger right away. You might consider giving them sedating antihistamines. And again, as I mentioned, you should monitor for any infection and treat appropriately. And then
Really, just then it all is down to coming up with the right diagnosis and then treating it as appropriate. So there's a various range of systemic treatments for psoriasis, PRP.
For atopic dermatitis, actually they usually respond to just intensive topical treatments, but again, you can consider systemic agents. If it's drug rash, you stop any essential drugs, and if it's appropriate, you can give them a short course of oral steroids. And as previously
Discussed for SJS or TEN,
you can give supportive care. So sorry now.
I know that was quite long-winded in some areas, but I hope that would be of some
benefit to you. And
thank you for your time.